You know, in the high-stakes world of a hospital, a doctor's ability to spot patterns can literally be the difference between life and death. But that exact same skill, that reliance on experience, well, it can also set a really dangerous trap. Today, we're going to dive into some of the most critical diagnostic pitfalls a clinician just can't afford to miss.
So let's just start with the question. Think about it. In the total chaos of an emergency room or a busy clinic, what is the single most powerful tool a doctor has? And what if I told you that same tool was also their most dangerous? It's their first impression, that gut feeling, that initial diagnosis that just pops into their head. It can save precious minutes and kickstart life-saving treatment, but it can also lead to something called anchoring bias. That's where a doctor gets locked onto that first idea and just fails to see other, way more dangerous possibilities hiding right in front of them. This bias, it's really at the heart of our first set of challenges.
All right, let's get into our first section. We're talking about cases where the symptoms themselves are the problem. They're deceptive, and they can point a doctor in completely the wrong direction right from the get-go.
Okay, so this right here is a classic medical nightmare. A patient comes in, they've got chest pain, their ECG has some changes. Everything is screaming heart attack. But the clues for an aortic dissection, that's a tear in the body's biggest artery, they're there if you're looking closely. The pain is described as tearing, not crushing. And there's a difference in blood pressure between their two arms. These are subtle for sure, but they have huge implications.
And those subtle clues? Oh, they matter immensely. See, the standard treatment for a heart attack is a clot-busting drug. But if you give that same drug to a patient with a tear in their aorta, well, the result is exactly what it says here, catastrophic. You're basically turning a small leak into an unstoppable flood. Getting that first impression wrong in this case is absolutely fatal. An overactive thyroid is another fantastic example of a mimic. When we think of hyperthyroidism, we usually picture someone who's shaky, super hyper, maybe a little agitated. But in an elderly patient, it can look completely different. It can show up as depression, or weight loss, or even just an irregular heartbeat. The classic textbook signs are just gone. It's a powerful reminder that diseases don't always follow the rules.
Now let's talk about sepsis for a second, a life-threatening reaction to an infection. When you think of sepsis, you expect the body's alarm bells to be going off like crazy, right? A super high fever, violent shaking chills. This is the classic picture we're all taught to look for. But what happens when the alarms are silent? Well, in an older patient, the response can be the exact opposite. They might not have a fever at all. They might even have a low body temperature. And sometimes the only sign of a full-blown, raging infection is just confusion. The scary part is, a normal temperature can give a doctor a completely false sense of security.
Okay, next up, let's talk about the danger in what you don't see. This section is all about learning to listen to the silence and recognizing when a period of calm is actually the most deceptive danger sign of all.
This one is terrifying. After a head injury, a patient might get knocked out, but then they wake up. They seem okay. They're talking. They're alert. This is called the lucid interval. And it is so tempting to think the danger has passed, but it's a trap. This is just a temporary calm before a bleed in the brain causes a sudden catastrophic collapse. That period of seeming okay, that's the real red flag.
And here's another kind of false reassurance. A patient comes in complaining about fainting spells or feeling their heart flutter. You run an ECG right there in the ER, and it comes back perfectly normal. Phew, great news, right? Well, not necessarily. A normal ECG is just a snapshot, a single moment in time. A dangerous intermittent heart rhythm could have been happening an hour ago, or it could happen an hour from now.
So if that one snapshot isn't enough, how do you catch these tricky on-again, off-again arrhythmias? Well, you have to watch the patient for longer. A clinician might need to send them home with a Holter monitor for a day or two, or use even longer-term monitoring just to catch the problem in the act. It's all about recognizing that a single, quiet test result doesn't close the case. All right, that brings us to our third section. Here, we're going to look at the pitfalls that happen when a doctor just fails to look beyond that first, seemingly obvious conclusion, or when they act on an impulse to treat before they really know what's going on. The therapeutic reflex is such a fascinating idea. It's that natural impulse to treat a symptom immediately. Got pain? Here's a painkiller. Inflammation? Here are some steroids. And look, it comes from a good place, but it can be really dangerous. By just blunting the symptoms, a clinician can accidentally hide the signs of the real underlying disease, something like cancer or a deep infection, and that just gives it more time to get worse.
This is a perfect example of looking beyond the obvious. So a patient who has rheumatoid arthritis comes in with one single really badly swollen joint. The easy first impression is to just blame it on their RA. It's just a bad flare-up. But the absolute rule here is you have to assume it's a dangerous joint infection until you prove it's not, and that means you have to draw fluid from that joint. You just can't assume it's the usual suspect.
And then, of course, there are those situations where there is absolutely no time to waste. These are the can't-miss, drop-everything emergencies. A collapsed lung that's making blood pressure crash, fluid that's literally crushing the heart, or swelling in a limb that's cutting off all blood flow. In these cases, spotting the pattern isn't just about getting a diagnosis, it's about immediate life or limb-saving action.
So after seeing all these mimics and deceptions and reflexes, how do we fight back? How do we avoid these traps? Well, that brings us to our final section, which is all about getting into the mindset of what we're calling the vigilant clinician.
The primary enemy we've been talking about this whole time is anchoring bias. We saw it right at the beginning. It's that mental shortcut where our brain latches on to the first piece of information and then sees everything else through that lens. It's what makes us believe that chest pain has to be a heart attack, or the swollen joint must be arthritis. To be truly vigilant, a clinician has to consciously fight against this pull.
So what are the practical triggers to fight that bias? When should the alarm bells really start ringing? Well, first, when the patient isn't getting better with the treatment you've given them. Second, when their symptoms are just weird or atypical. And third, when that little voice in the back of your head says, you know what, something here just doesn't feel right. Those are the moments to stop, take a breath, and reassess everything.
And really, this is what it all comes down to. This is the crucial takeaway. True clinical excellence isn't just about having an encyclopedia of diseases in your head. It's about intellectual humility. It's about constantly asking, what else could this be? And having the courage to admit when your first impression, your most powerful and dangerous tool, might just be wrong.